Before we get into an analysis of the relationship between substance use disorders and psychiatric conditions and the possible theories of comorbidity, it might be helpful to review the major syndromes that overlap with substance use disorders and the prevalence rates in the general population of comorbidity. One of the main types of psychiatric disorder that overlaps with substance use disorders is mood disorders. And there are three major types of mood disorders: unipolar disorder and bipolar disorder. Unipolar means that it's either mania or depression. Bipolar disorder means it's both. The second major category is major depressive disorder. And major depression sometimes has psychotic symptoms, and sometimes it has atypical features. What this suggests is that even in conditions which are well known, like depression, there are many different varieties, which makes it difficult to come up with a very specific diagnosis. The third category is dysthymia, which is a milder form of depression, which has some but not all of the symptoms. Let's just talk about major depressive episode. This, according to DSM criteria, requires 5 or more of the following symptoms to have been present during the same 2-week period, and also to represent a change from previous functioning. So, in order to diagnose depression, the questions in a structured or a semi-structured interview will ask about whether or not during a 2-week period, during the past year, a person experienced depressed mood most of the day, nearly every day for those 2 weeks, as indicated by feeling sad, empty, or hopeless, and or being observed to have been like that by other people. Another symptom is diminished interest or pleasure in activities most of the day that formerly brought joy to a person's life. So there needs to be a diminished interest or a lack of pleasure in life during that period. The other symptoms are somewhat contradictory, but it could either be weight loss or weight gain, insomnia, or sleeping too much, or psychomotor agitation or slowing down. But in all of these cases, it's something that deviates from the norm, either in terms of more or less. And finally, feelings of guilt and feeling worthless are part of the syndrome of depression. Depressive disorders can be confounded or mixed up with other medical conditions. So thyroid disease, Cushing's disease, tuberculosis, lupus, head trauma, Alzheimer's, all can lead people to have symptoms that might look like depression. In some cases, medications, heart medications, hypertensive medications, chemotherapy, oral contraceptives can produce those symptoms. And as we will learn, alcohol, sedatives, withdrawal symptoms from cocaine and stimulants can induce the same kinds of symptoms. So sorting out the origins of depressive symptoms in order to provide a proper diagnosis can be quite difficult and requires a skillful clinician or a structured interview that gets into all of these different areas by systematically asking patients to first describe their symptoms and then to eliminate other medical conditions, medications, and the use of substances. Beyond depressive disorders, anxiety disorders are quite frequent in people with substance use disorders. And anxiety disorders are a blanket term covering several different types of anxiety. Recent surveys have found that as much as 18% of Americans may be affected by anxiety disorders. The major categories that overlap with substance disorders are generalized anxiety disorder, GAD, panic disorder, phobias, and social anxiety. GAD is a common chronic disorder characterized by excessive anxiety that is not focused on any one object or situation. Phobias, for example, produce anxiety, but they're focused on particular types of fearful objects. People suffering from generalized anxiety disorder experience nonspecific persistence, fear, and worry, and become overly concerned with everyday matters. And GAD is most common of all the anxiety disorders to affect older adults. Panic disorder is another type of anxiety disorder. Brief attacks of intense terror or apprehension, often marked by trembling, shaking, confusion, dizziness, nausea, and difficulty breathing. And panic attacks usually last only for about 10 minutes or so, but they can also last for several hours if they're triggered by stress, fear, or even by exercise. The comorbidity of panic disorder with major depression is anywhere between 20 and 60%, and with other anxiety disorders as well is pretty high. With substance use disorders, comorbidity or co-occurrence is about 15%. Social anxiety is an intense fear of negative public scrutiny or public embarrassment or humiliation. It keeps people from going into social situations, and the physical symptoms include blushing, sweating, and difficulty speaking. Again, this is a condition that overlaps with substance use disorders. Other types of disorders that overlap with substance use disorders are trauma and stress-related disorders. PTSD results from a traumatic event such as a combat exposure, a natural disaster, a rape, hostage situations, child abuse, and from long-term chronic exposure to severe stressors. The common symptoms of PTSD include hypervigilance, flashbacks, avoidant behavior, avoiding anything that might potentially be threatening or anxiety-producing, and anger and depression. It's often observed in soldiers who endure individual combat but can't cope with continuous exposure to highly anxiety-producing situations. PTSD has a prevalence rate in the general population of 3 to 5%. Its course based on exposure is often in the early teens to the late 20s, and it's comorbid with depression, anxiety, and substance abuse, as well as alcohol dependence. Schizophrenia is a very debilitating psychiatric disorder, which is diagnosed with 2 or more of the following psychotic symptoms: delusions, hallucinations, disordered speech and thought patterns, grossly disorganized or catatonic behavior when the person is totally unresponsive to their environment, and symptoms of diminished emotional expression. Psychiatric disorders characterized by psychotic symptoms can be precipitated by hallucinogenic drugs and by amphetamines. And although their prevalence rates are not high, they are extremely debilitating. So in summary, comorbid cases are different than cases of substance use disorder where the person doesn't have a psychiatric condition. They have poorer clinical course than other cases, and people who have comorbid conditions see themselves as much more disabled than those with a single substance use disorder or a single psychiatric disorder. Comorbid cases usually require more intensive treatment, and they are represented in a much higher degree in health services than people without psychiatric conditions. So people coming into emergency departments and showing up to doctors for a variety of different medical illnesses are much more likely to have medical conditions when they have comorbid psychiatric and substance use disorders. A big factor in comorbidity is what is called externalizing disorders, which are disorders of personality and behavior that make a person particularly susceptible to developing a substance use disorder when these personality disorders develop early in life, which they generally do. So it becomes difficult to sort out causes and effects for many psychiatric conditions in terms of their relationship with substance use disorders, because they tend to begin at about the same time. But for externalizing disorder, they generally appear in advance of both substance use disorders and psychiatric disorders.